today's lecture. During this week, we are going to discuss the physiology, the properties of blood and body fluids. Today we have two lectures. The first lecture I'm going to present. Second, I'm going to discuss some basic terms characterizing the body fluids and compartments, older compartments of the body. Next lecture will be held by Professor Bene, who is going to discuss the properties of red blood cells and will explain the blood types. Third lecture will be on the hemostasis and the enterohepatic circulation of the degradation products of the red blood cell, the hemoglobin. And the last lecture, which is on Friday, 9 o'clock, if I'm correct, Thursday maybe, I'm invited clinical hematologist, Professor Ina Sabo, who is going to explain the use of blood derivatives in human therapy. He's a practicing hematologist, and in the last lecture, he's going to show us what type of blood derivatives are used in the therapy. We know blood transfusion is the most frequently used organ transplantation. What is an organ? And he is going to show how many different ways the blood can be used in human therapy. So, let's start the first lecture on the body fluids and homeostasis. Today I'm going to explain some basic terms which are used in both characterizing the behavior of body fluids, and they are also used in clinical practice. We are going to clarify some definitions, and we are going to understand how water or solids move between the different compartments of the body. Well, explaining definitions in a lecture is not a really fascinating program. So, hoping that you have all the lecture slides, please lay back and try not to fall asleep during the next 40-50 minutes, while I'm going to dump a long list of definitions on you, and maybe between two definitions I try to insert some explanation why it is so important. So, let's start. Body as an open system. We are going to start several times at this point during our physiology course, referring to that body is always in a continuous exchange of matters and energy with the environment. This is what we call open system. So the steady state condition, the steady state of the body, which is actually the goal of the physiological regulations to maintain the steady state conditions of the different parameters, physiological parameters, is achieved by regulating the uptake of substances from the environment, and of course also to eliminate those substances which are not necessary for the normal function of the body. The particular methods how this uptake and elimination takes place in the body is not of the focus of the today's lecture. Different chapters, GI tract, kidney physiology, and others, deals with this question. What we want to see today, how we characterize the steady state conditions. What are the parameters what we study when the steady state is discussed. So, we are an open system, and as we know, a multicellular organization like the human body has to maintain the normal function of the cells. In a single cell, which is in a direct contact with the environment, and the substances are exchanged directly between the cell and the environment, this is very simple. The whole cell takes care of all of these functions. In a multicellular systems, during the evolutions, the evolution developed a special environment, a special microclimate which surrounds the cells. This is what we call internal environment. The term was introduced by Claude Bernard, the famous physiologist. And this internal environment, or milieu intérieur, anybody speaks French here? I hope my pronunciation is not too bad. So this milieu intérieur will function as a buffer between the environment and the cell. So this is an intermediate state where substances are taken up or can accumulate, or from where these substances are eliminated into the environment in order to maintain the steady state conditions of the cells. The process, how it is achieved, is called homeostasis. Homeostasis is the process how the equilibrium of the body is maintained without entering into the details of the processes like the kidney, GI tract, and so on. So this is what we call homeostasis. Be aware of that there will be another term which sounds very similar to the hemostasis, the clotting of the blood. So when you do the test, it's really important to read at the self-control which word is used in the questions, because they refer to two very different processes or terms in the physiology. What are maintained? The composition of the fluids, like ionic concentrations and the concentration of organic compounds in both intracellular side and this milieu intérieur, the temperature, pH, and on and on and on, a lot of parameters of the body should be maintained, and this is what we call homeostasis. At first step, I am going to focus on the water. Water content of the body must be maintained and in equilibrium, so in steady state conditions. And as an open system, of course, the uptake and the output must be equal. This is actually what how the equilibrium is achieved. Ladies and gentlemen, the sources of the water in case of the human body basically are the fluid what we drink, the ingested water. This takes about 90% of the water, and there is a small quantity of water, roughly 10% or less than 10% of the daily water intake, which origins from metabolic processes like oxidizing carbohydrates, lipids, where the hydrogen, when it is oxidized, is going to produce water. In the different animals, in different creatures, the proportion of these two types of inputs can be very different. For example, freshwater fish, which practically has free access to water in their environment, takes up water many different ways, like gills or skin, so there are many others. This is one extreme situation when the animal, the living creature has practically no limitation for the water. Other extremities, like some desert animals, which can limit the water loss in significant extent, since their access to the water is also limited. The majority of the water origins from metabolic sources like oxidizing these carbohydrates and lipids. One extreme example I frequently mention to my students is the so-called kangaroo rat. This desert rodent which can live without drinking. It can feed on dry barley or oat, no fruits, no vegetable needed, just the dry food, and simply the water coming from the oxidized nutrients will be enough to maintain its equilibrium, but we are not congruents. We need 2.5 liters of water every day. This 2300 milliliter of water, actually, the minimum quantity, what we need to maintain or regulate the FDA recommendation is 3.5 liter or 4 liter of total water. Of course, when I say water, this is not only the water that we drink. All other waters found in fruits, vegetables, or in the food also add to this amount. So roughly, we need 2.5 liters of water daily in order to maintain our water equilibrium output. On the output side, the largest amount of water leaves the body via kidney. This is the urine, and this is what we will see in the later part of our study, is highly regulated. There are some other outputs or fat to leave the body in the sweat, on the feces, where roughly 200 milliliter, this is not a significant amount, of water is lost every day. And there is a term, so-called insensible, perspiration insensible, what we have to define this time. In the urine, in the feces, the water content can be easily recognized. 99% of the urine is practically water. However, the evaporation from our skin or lung can also form route for the water to leave the body, and in this case, significant amount of water. Altogether, as much as 500 to 700 milliliter of water can leave the body. This so-called perspiration insensible in many respects, insensible in many terms, insensible to the conditions of the body. It is not regulated. Whatever is the water conditions, either we are in shortage of water or free access of large quantities of water, either we drink or not, this water will be lost. This cannot be regulated. We can regulate this part only. This is one part. So we have this insensible water loss. We have some almost insignificant water loss via sweat and feces, and we have the urine. And since this is a medical school, we have to account some pathology conditions when, under pathology conditions, the water loss can be increased significantly. Bleeding actually is not the most dangerous way, to lose water. Bleeding has its own dangers, of course, reducing the circulating blood volume, but still we can lose some water via this way. However, the other two, vomiting and diarrhea, under clinical conditions can lead to significant loss of water. This is what the physician has to recognize and has to be able to compensate when certain pathology conditions are present. The same way as we have these pathologic losses, under pathologic conditions, the physician can use another route, a direct route to add water, the infusion, when crystallines and water are infused into the circulation in order to compensate the water loss when the normal uptake routes cannot function or not accessible. The same way as we maintain the constant water volume of the body, we have to maintain the constant concentration of electrolytes and other substances in the body. The behavior of the electrolytes is basically the same as the water. Like water, we consume electrolytes, so they come from the food what we take, and the same way they leave the body, renal excretion, stool, sweating, and importantly, again, under clinical conditions like diarrhea, large quantities of electrolytes can be lost with vomiting or diarrhea, which also must be considered by the physician when dealing with such a situation. So we have the physiology roots to live, and we have the pathology roots. Electrolytes are not metabolized. After entering the body, we either eliminate them or store them, but this intake and elimination is going to constitute the balance. This is what the regulation should achieve. We have so-called metabolized substances what the metabolic activity of the body, for example, glucose, carbohydrates, other chemicals. In this case, the output route is different when we metabolize the fats, the lipids, the carbohydrates. They are exiled as carbon dioxide and water. Source are like electrolytes, but their amount can be reduced without eliminating it from the body. At this slide, I usually apologize to my students because it might look strange. In the second year of the medical school, we are discussing the way to express concentrations and what are the SI units of concentration. However, my very sad experiences on the oral exams always force me to point the importance of the unit of measures, how we express the concentration. For some reason, especially in the very special emotional situation of the exam, students tend to forget the importance of the unit. Ladies and gentlemen, whenever we are talking about parameters, when concentrations are questioned, always add the unit of measure to the concentration. Believe me, it is absolutely not the same situation if somebody has 20 micromole bilirubin in the blood plasma or 20 millimole bilirubin in the blood plasma, highly toxic. Nobody can survive. So it's always important to memorize the unit of measure. What unit of measure we use? Molarity, molar concentration. What in physiology is used most time. This is what the standard, the international standard defines. The number of moles in liter of solution, and of course not only mole per liter, but millimole per liter, micromole according to the concentration. But you are going to see during your study somehow physicians like to keep their old-fashioned units. You are going to see there will be some parameters, especially the old traditional parameters that are used to characterize the body function, like hemoglobin concentration. You also know the blood pressure. You know, unit for the pressure is, what we use, millimeter of mercury. Nobody else uses this, but somehow physicians try to do it. You know, when I was a student, it was a very long time ago, in the early 80s, this was the time when we switched to SI, to the international standards, and that time we were forced, as students, to use Pascal when we measured the blood pressure. Of course, when you are new in a business, it doesn't really make a difference to you whether you use millimeter of mercury or Pascal, and the chairmen of the clinicians all try to force their colleagues to switch to the new units. Before this, everybody used a millimeter of mercury. What was the result? We bought, the device to measure, the new device. In the scale, we had Pascal. Of course, the physician with a marker just wrote the number with hand. So 15 Pascal is equal to 120 millimeter of mercury. When we wrote down the results, they required us to write in parentheses, the number expressed in millimeter of mercury. So somehow in this profession, certain units survive the switch to the metric and international standard. And for example, the hemoglobin concentration will be one of such a unit. We use gram per liter. This is very frequently used, probably the older generation, I didn't see that officially, okay, the older generation couldn't change the way of thinking. I was second-year student at that time, so it didn't really matter to me to memorize. The hemoglobin concentration would be expressed as millimole, 2.2 millimole per liter, or 150 grams per liter, doesn't matter, but somehow the later one survived, and remembering that molarity is the official unit, in certain cases we will use different units. When we are determining concentrations, we have to be aware certain things. Point one, body fluids are not optimal fluids in that sense. When physics and chemistry deals with fluids, those laws which describe the behavior of those fluids are determined on very diluted fluids. Body fluids are not extremely diluted. It's like blood plasma, where we have 7% protein in the plasma, which is very concentrated. Those proteins will constitute a big surface, and many times they can buffer certain compounds from the plasma. So the total concentration in the plasma will be different from the free concentration, what is dissolved in the water. One ion, calcium will be, for example, this. We are going to memorize 2 calcium concentration, the total calcium concentration, 2.5 millimole per liter, but this is not ionized. Only half of this calcium is ionized, half of the calcium is bound on the surface of proteins. So we have to remember bilirubin, for example, the majority of the bilirubin is bound on albumin, not in free form, which means it cannot be filtered by kidney because it just simply attached to the surface of proteins. So that can, this sometimes can generate differences in the free solute concentration between the free solute concentration and the total concentration of the plasma. Concept of compartments. As we all know, the body fluids are compartmentalized. What compartments are? Compartments are subspaces of the body separated by barriers, which barriers limit the diffusion of substances from one side to the other, so between the two compartments. In our body, we can distinguish several subcompartments. If this red square is the total body, within this space we have subcompartments. So we have the compartment, subcompartments, and diffusion barrier as terms. The body, of course, is very complicated, so several subcompartments are parallelly organized, and within one subcompartment we have further subcompartments, and we are going to see what compartments we distinguish within the body. What we have to remember only, to enter from one point to the other, we usually have to cross this diffusion barrier, which always slow down the diffusion of substances. What type of compartments we know? First, to be mentioned, we have the intracellular fluid or cell water, and I don't think this needs further definition. This means what it means, the total water content of the cells. Of course, this water, the so-called cell water, is subcompartmentalized, huge number of cells. They are not interconnected with each other. These are just simply the deepest compartments in the body. So basically we have the intracellular and extracellular fluids, and altogether the water content of the body will be roughly 60% of the total body weight, and the intracellular space is larger, the extracellular space is somewhat smaller. We can see this buffer, this milieu anterior, smaller than the total living tissueness of the body. It is only 24%. What type of subcompartments we have in the extracellular space? We have the blood plasma. Blood plasma, which is roughly 3 liters, one of the most frequently mentioned subcompartment. We can deal either with the blood volume, in this case that will be 5 liter, or the plasma volume, blood volume minus the volume of the red blood cells. So this is 3 liters. Why it will be very important, of course, when we are going to start the chapter of the circulation, we will learn how this compartment will transport certain substances to the body, but at the same time, this is the compartment what we try to primarily access during medical activity, intravenous injection or absorption of medicines from the gut into the blood, accesses directly this compartment. The importance of this compartment cannot be overemphasized. Several times it will be mentioned and discussed. Interstitial space. This is the most difficult to define because this subcompartment does not have barrier. Why the plasma water is the total water content which is located in the vascular bed, in the vessels. Interstitial space is defined as the extracellular space in close proximity with the cells. Not a really sharp definition, I think, we agree. However, because of diffusion properties, this term is frequently used. This is the largest subcompartment of the extracellular fluid. The remaining 6 liters of the extracellular fluid that we have is subcompartmentalized into small fragments, small volumes, including like the vitreous fluid in the eye or the fluid in the joints, which altogether are less than 1 liter. Under physiologic conditions, the volume is not high, which doesn't mean these are not important, of course. But under pathologic conditions, one or other can, the volume of one or other can be increased. Basically, when a pathologic fluid accumulation takes place in the body, there are 2 theoretical ways how this body can be produced. Either the hydrostatic pressure can increase in the vessels and filter out the fluid from the capillaries into the extravasal space. This is what we call transsudatum. In transsudatum means fluid is filtered out through a physiologically functioning barrier, which means in our case, protein content of this fluid will be very low. Usually this fluid is clean, looks like a water, no proteins, and the density is very low. So this always originates from high intravascular pressures, which filters out the fluid directly from the plasma. The other type of pathologic accumulation is the so-called exudatum, when most time, because of inflammation of the tissues, the barrier, the permeability of the barrier, like the capillary wall, increases, and the normal hydrostatic pressure is going to filter out increased quantities of water, the water that can accumulate, but because of this reduced barrier, this water contains plasma proteins or other inflammatory proteins. So this fluid will be turbid. Usually protein content is high and the density is very high. How can we measure the volume of these compartments? Here I am going to explain the so-called indicator valuation method, which can measure the volume of the different subcompartments, and this is what you almost surely will never do. In clinical practice, we usually do not measure this volume. These are assessed by other methods. Why it is important? Because when you administer any medicine, the distribution of the substance, the distribution of the medicine is going to follow the rules of the dilution method. So every day when you prescribe pills, drugs, or inject you are going to use the indicator dilution principle to deliver your medicine to the desired compartment of the body. So what is the dilution principle? How can we measure? It's easy to understand when the water content is distributed along the body. How can we measure the total? The dilution principle states the following. If we have a volume to be measured with unknown extent, so we don't know what is the volume, and at the same time we have a small volume of indicator. Small volume is very important here because the added volume should not change significantly the total volume of the volume to be determined, and we know the concentration of the indicator in this volume. If we add it, we wait until it distributes evenly, then we determine the concentration. From this data, we can determine what was the original volume. Very simple. The definition is probably more complicated than the principle itself. You want to determine the blood volume. What you do, 1 milliliter or 2 milliliter indicator injected intravenously, you wait 10-15 minutes while it distributes into the blood. You take a blood sample, you determine the concentration, and from the original volume and from the original concentration, this simple calculation is going to give you the volume of the blood. So this is how an unknown volume can be determined. So the indicator method, what we use, give us this time function of the indicator concentration in the compartment. Having one compartment, when we inject the indicator distributes quickly within a few minutes, like in the bloodstream, and is going to reach a steady state concentration. When we take the sample from here, we can perform the calculation. Yes, but we said we have several subcompartments. So how a so-called multi-compartment system behaves under this condition. Let's assume we have two compartments. The two compartments is interconnected with each other. We can access compartment 1, but compartment 2 can be is accessible only through compartment 1. So what is the situation here? We inject the indicator into compartment 1, same situation as injecting an intravenous injection with a drug. Usually the subcompartment, because of the semipermeable membrane, the diffusion barrier, the equilibration of the substance in the subcompartment is slower. So usually we have a high peak of the indicator at the beginning, then as the concentration equilibrates between the two compartments, finally we reach a steady state concentration. So after this transient period, when we determine the concentration here, we can make the calculation, and we can determine from the kinetics of this curve, we can determine the two compartments. The same rule applies to a three-compartment system, and what type of compartments we are dealing with in a medical activity. For example, let's say somebody has a pneumonia, and the pneumonia is treated with antibiotics. Usually, what we do, we prescribe antibiotics. It's taken in the form of pills. The patient is going to intake the pills. It is absorbed into the blood. So from the GI tract, it goes to the first compartment. Then we have a barrier between the interstitial space of the lung and the blood. These are the capillary walls. The drug has to be able to penetrate this capillary barrier to enter into the desired target, into the lungs. Sometimes this barrier slows down the diffusion extremely. So for example, having a pneumonia, usually 7-10 days of antibiotic treatment is enough to heal the patient. But for example, if somebody has an osteomyelitis, which is the infection of the bones, since the barrier between the blood and the bone is much more limited it limits the diffusion to much higher extent, when we deal with osteomyelitis, usually the treatment time is several weeks because the equilibrium, the desired concentration of the antibiotics in the bone is going to equilibrate much later. So these theoretical compartments will be everyday problems for you when you when you prescribe medicines, but you are going to call them connective tissue, you are going to call them organs, you are going to call them blood or bones. This distribution, so this small subcompartment, as I mentioned, the bone, the transcellular and plasma compartments, take out a smaller fraction of the total water content, as now we normalize the water content to the total water content of the body. Previously, we defined as the percentage of the body weight. So if 100% is the total water content, the cell water is 60%, and here we have, as we see, the interstitial fluid is the biggest, and we have several subcompartments, bones and others, which are also present. This is a list of indicators, what we can use to determine the different compartments. The take-home message, actually, from this list, this is, as I mentioned, this is not this technique is not used every day in the medical practice. What we can learn from this table, when we measure the total body water, usually we use the water itself to measure the distribution. Using measuring the plasma volume, we use large molecules, and there are certain subcompartments which can be determined only by mathematical subtraction of one compartment from each other. So sometimes so-called indirect determination is required. Osmotic consent, osmosis. We said we want to regulate, we have to regulate the water content, we have to regulate the concentrations, and that is a parameter which frequently missed. This is the osmotic activity or osmotic concentration of the solutes in the compartment. What is the osmotic consent? If we have two subcompartments separated by a semipermeable membrane, and the given substance has two different concentrations in the two subcompartments, and this barrier is impermeable to the substance, the concentration difference is going to move the water from one place to the other, actually from the diluted place to the high concentration, the water is good. This is the osmotic phenomenon. So when the substance cannot diffuse through the barrier, water is going to diffuse in order to equilibrate the concentration difference. That will have several unwanted consequences. For example, one possibility, these chapters will be discussed later, but for example, in diabetic patients, when the blood glucose concentration is not controlled properly, and the hyperglycemia is maintained for several days, this increased blood glucose concentration will penetrate, the glucose is going to penetrate into the brain, and the glucose concentration will be higher, also the metabolic concentrations is increased in the brain. Now, if we normalize the blood glucose concentration in a short time, undesirably short time, so within a few hours, glucose and the metabolic substances have no time to diffuse out from the brain, but the water is going to diffuse into the brain, and it results in brain edema. Since the skull limits the volume where the brain can expand, this way can generate a life-threatening situation. So, osmolarity, the total number of dissolved particles in the solution, and if the solute cannot move, the water is going to move. Here are definitions. We measure the osmotic concentration, the total activity of particles in the solution, And the same way as sodium, potassium, or other ion concentration must be maintained, the same way the osmotic concentration of the body fluid also has to be maintained. The normal range for osmotic concentration is 280 to 290 milliosmol per liter. When the osmotic concentration is smaller, we are talking about hyposmotic or hypotonic solution. When it is higher, hypertonic or hyperosmotic solution. We should understand this osmotic concentration difference, especially when we inject drug into the tissues, can stimulate neurons the same way as potassium ions or sodium ions can imbalance the resting membrane potential. So for this reason, the subcutaneous or intramuscular injection of hyposmotic solution is painful. It directly stimulates pain receptors. Therefore, when an ion or SC injection is produced, its osmotic concentration must be physiologic in order to prevent this unwanted side effect. When we inject something into the blood, interestingly, since it mixes very quickly and we have no receptors in the blood, this is the organ which doesn't have any type of neurons, it will evidently be not painful. So you can inject hyperosmotic or hyposmotic solutions into the blood, but nowhere else. Okay? These terms describe the different parameters of the body fluid, and now quickly we are going to review some frequently used terms, what is used in the clinics, and we are going to use them during our physiologic studies as well. Normovolemia, hypervolemia, hypovolemia. During this whole lecture, I talked about volumes. Volume of subcompartments, volume of this, volume of that. When in medical practice we are talking about hypervolemia, this refers to the circulating blood volume. Only to the circulating blood volume, so not the total water content. When we are referring to the total water content, we are using the terms extracellular fluid volume. Extracellular fluid volume, which can be also increased, decreased, but it is sharply separated from the hypovolemia. When a physician said a patient is hypovolemic, that simply means not enough blood in the vascular tract. Okay? When it says decreased ECF, that means the total water content of the body is reduced. When the extracellular fluid content changes, either increases or decreases, it never leaves untouched the intracellular fluid content. So these are very tightly interconnected. When one starts to increase, the other will follow it within a few hours. Special term, the dehydration, when, or exicosis, when the water content of the body is reduced and the extracellular fluid volume is decreased because of the removal of water from the body, exicosis. While ECF volume change is independent from the concentration of the different crystalloids, the ions, so you can have hyperosmotic increased ECF or hyposmotic. When we say dehydration, that always means reduced water with increased concentration of ions in the body. So we just remove the water. Sodium is a crucial component of the body fluids. We are going to see this ion or this component determines the total body water volume. When we add sodium to the body, the compensatory mechanism will accumulate water, and this expands the water volume, so that increases the extracellular volume. Therefore, we can use the measure of the body sodium content as a measure of body water content, so they are always almost like parallel. In hyponatremia, when the concentration of the sodium decreases, usually indicates increased water content. The dilution results in the decrease of the sodium concentration. Dehydration, usually accompanied by increased sodium concentration, we remove the water, so the remaining sodium gives higher concentration. So this will be always a parallel change. Other components, potassium, calcium, magnesium, and others, usually can change without affecting the water content. But we will see when the sodium is eliminated from the body in large quantities, let's say because of a malfunction of the kidney, water is going to follow it, and it will result in reduction of extracellular fluid volume. This doesn't stand to the others. Osmolarity, same logic applies as with the sodium. When we reduce the water content of the body, that increases the extracellular osmolarity and vice versa. And there will be certain conditions which will imbalance the osmotic equilibrium of the body, like diabetes insipidus, when the large amount of water what is lost is going to increase the osmolarity. When the osmolarity is imbalanced by either increasing or decreasing, from clinical point of view, it has to be normalized the same way as the sodium or other content has to be normalized in the patient. Therapy, so-called fluid therapy, is a crucial point, a very critical part of medical activity, especially in the ER room. You will see several times when following a huge blood loss, hemorrhage, or dehydration, acidosis. Immediately the missing compartments, the missing components have to be replaced. Luckily, today the clinical labs provide within 5–10 minutes the required data, and the physician can judge from one single blood sample what happened with the body fluid content, which ion is missing, and directly can compensate the water loss. And we use isotonic, hypertonic, hypotonic solution, always what requires to normalize the body content. Ladies and gentlemen, thank you for your attention. In 10 minutes, we are going to continue with the rest of